right, welcome. Hello, everybody. My name is Elma, and welcome to today's webinar. I'm the coordinator of the BOLD Public Health Center of Excellence on Dementia Caregiving. We are thrilled to have you here all together with us. This is our first webinar in this month of May. And I would like to start today's session by grounding us in our land acknowledgement. Whether it's in the physical or virtual space, University of Minnesota, we work and we are located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people, and we take to heart and commit through our actions to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity, which I'm sure you will see reflected in today's webinar, as well as in the work that we do through our center. Next slide, please. Many of you are probably familiar with our center, but for those of you in the audience who are here for the first time, the BOLD Public Health Center of Excellence on Dementia Caregiving really is designed to support the work of state, tribal, and local public health agencies nationwide as they develop their infrastructure, their programming to support dementia caregivers. We do that by improving access to evidence-based programs and best practices in public health. And we help facilitate connections between public health providers, public health agencies, and a wide range of other service organizations supporting family caregivers of people with dementia. And we also provide technical assistance to public health departments for identifying and selecting effective public health interventions and strategies to support caregivers in their jurisdiction. You can learn more about us by scanning the QR code. A few reminders for today's session. Please, in your Zoom bar, use the Q&A feature as questions come up to submit them to our speakers. Some might be answered as we are speaking, and others will be answered at the end during the Q&A time that we have allotted. The recording, the slides, and all resources that our speakers shared today will be shared with you all after this event. And please, we really take seriously your feedback and use it to improve all of our center's programming. Thank you in advance for providing it. You can scan this QR code or open the link that will pop up automatically in Zoom when you leave today's sessions to provide some feedback about how we did today, what worked, and what we can improve upon. Before we start, we are in a virtual space and we really want to see who all is in the room today. So my colleague Ashley is going to launch a brief poll to see who is here. Please select the capacity you are attending in today's event. Ashley, I don't know if you can see the responses, but I am not able to see that any are being submitted yet.
Sure.
So feel free to.
Okay, we'll give it just another second here and then I'll end the poll.
Sure.
All right. Are you seeing the results?
Oh, yes, thank you. We have about a third of you here are community organizations, service providers, followed by BOLD public health agencies and non-BOLD public health agencies. So about 30% are also public health departments. Welcome. We also have a few caregivers and community members, as well as care clinical professionals. Good to have you all here. This really helps our speakers as well know how to best tailor their presentation and what to share. Thank you very much for responding. Next slide. So we are very excited to present today's topic. Developing a dementia-capable workforce is a core function and a priority for public health. And many public health departments already collaborate with professional organizations and academic institutions in their states to help create dementia-specific training curricula for healthcare providers in various roles, whether it's primary care physicians, physician assistants, social workers, nurse practitioner, etc. And as we know, in dementia care, family caregivers play a central, essential role, collaborating with the healthcare team to develop the healthcare plan and provide a great amount of supporting care to the patient, to their loved one, outside of the clinical space, in the home and community, improving the quality of life. For this reason, it is important to equip our healthcare providers with the skills and tools to effectively communicate and engage with family caregivers in providing care. So today, to support this work, we will be presenting, we're honored to introduce CAPCT, which stands for Caregivers as Partners in the Care Team, a leading and a first of its kind that we are aware of, training curriculum to equip healthcare providers with skills, knowledge, and resources to effectively support and integrate family caregivers into the care team. So we really hope that today's session is going to be useful to you all, and especially to those public health departments here in the audience, that you will get ideas for what you can use and do in your state, in your community, and perhaps use the CAPCT in your work as well. Without further ado, we have a great group of speakers today. We will begin today's session hearing from Mr. Jose San Martin, a caregiver, about his experience caring for his wife who lived with dementia, and also his experience working with the healthcare team who supported her and him. Next, we will hear from Dr. Ana Choros from UCSF, Division of Geriatrics, where the CAPCT program was developed. And we will close the session with a conversation with Ms. Carolyn Tremblay from the South Carolina Department of Health, and Dr. Klzinski and Trong from the University of Oklahoma, who will speak about their work in their states to support, to educate and help equip providers to better work with caregivers in the clinical space, dementia care. So to kick us off, Señor Jose, bienvenido a la sesión de hoy. Welcome, Mr. Jose. It's an honor to have you here. Thank you in advance for sharing your experience with us.
Thank you so much. And if I get stuck with my English, I will be checking out with Elma for her to help me with it.
You are doing awesome. Could you tell us briefly about your caregiving journey, Mr. Jose, who you cared for, and your experience with care providers along the way?
Okay, great. Thank you. Yeah, my name is Jose San Martin. My wife's name was Connie San Martin. And Connie and I were married for just over 30 years. Actually, today will have been our 32nd anniversary. So it's a happy anniversary to us. And the experience, I'm gonna try to go as quickly as I can with this. The journey, I think it started around 2010, maybe a little bit after that. But we really don't know when things got going and when things became kind of a problem. So my wife was taking care of her dad. Her dad was suffering from congestive heart failure, and he passed away in 2009. And her mom was also having some issues. We don't know if the issues were caused by dementia. Probably they were. But I think those were contributing factors for us to notice that there were some things with Connie that they were not quite right. And we start going to visit her primary physician, primary caregiver, and her doctor just suggested a few things, and we were focusing on, first of all, on the stress that she was experiencing from still working. She was still working, even though it was only like 2 or 3 days a week, but taking care of her dad, and also keeping an eye on her mom to see how things were going. The doctor kept coming up with things like some of the things that Connie had was low sodium, faulty, low iron in the blood and things like that. Things that kind of made some sense, but when we tried to correct those things, we were not getting the results that we wanted. And this went on for maybe a year or two, and she seemed to be getting a little bit worse. And the symptoms that we were experiencing were symptoms where my wife was a type A person. She was always on the go, always very energetic. She loved life. She loved people. She loved her job. She was always excited about getting up in the morning. And those kinds of things were changing. And that kind of zest for life was changing in the ways that we were not able to put our arms around it. Then eventually, what she did was she began herself to do some research on her own to try to figure out what was going on. And she kind of auto-diagnosed with herself with Parkinson's. A few days after that, we visited with a neurologist in the Twin City area, and the neurologist did confirm that in reality she did have Parkinson's disease. That was a difficult one because she did not have um, tremors, so it was hard to figure out that that was Parkinson's. She will have tremors, but only during the night, and I will feel the tremors. But during the day, she didn't have tremors. About 5% of the people with Parkinson's do not have tremors, so that was kind of a difficult one to adjust to that or to figure out that's what it was. So anyway, we started the regimen of the treatments and so forth and medications. But that one thing that we learned right then and there was that we had to have a mind change about how we related to medical staff. Typically, being a little bit older, perhaps, than our children and grandchildren, we found out that the medical staff was not a good idea to treat the medical staff with the authority that had been given to them in the past of you are the medical staff, you know what's going on, you tell us what to do, we will do it, we'll get better. That was not quite the case. What was happening is we were discovering that from that moment on, we were going to have to develop a partnership with the medical staff. In other words, this is what is happening at home. This is what we are telling you. Does that resonate with you? How can this be addressed? So it was more of a partnership that we were having with them, and that was very helpful. But at the same time, I'm sorry. Yes. Yeah.
No, I'm sorry to interrupt you, Mr. Jose. So it was a partnership that built over time that you developed as you cared for your wife and you helped that care team really support her. And as you think back to that time, and I'm sorry, in a few minutes just that we have left, what things do you wish the providers had known or have maybe done differently to better support your wife and you in your caregiving journey as you think back to those years?
Yeah, and I think that your organization is on the right track with that. And what I noticed is that it would have been great if I would have had some kind of short introduction to what to expect from a long-lasting chronic illness like dementia and Parkinson's. And not only what to expect, because that is very difficult to come up with that because it relates so much to the specific person, but also what are trends? What are the trends that we should be looking for? This might be happening at this point. This might be happening at that point. This is how you should address these. This is what you need to do. Up to the point of maybe creating a list of the medications that she takes, when she takes them, what kind of diet she's having. All of these things because you can have those lists and those that information available in the event that you were out of commission for whatever reason. And so that is a very important thing to have. So all of those kinds of things, I think they are very good things to have as a training feature for a potential caregiver. Just because otherwise the caregiver is going in blind, he doesn't know what's coming up next or anything like that. The other thing too is deal with illness in a forward motion instead of responding to what the illness was 3 or 4 months ago. You're not going to see medical staff for at least 5 or 6 months or every 5 or 6 months. And if you address the issues that you've been having in the last 3 or 4 months, that's old stuff. So you kind of have to forecast what's coming up ahead. So those are mindset changes that I believe that need to take place. Other than that, try to have as many ducks in order as you possibly can, and that is an ongoing effort. The other thing too is to remember that as a caregiver, it is important for you to realize that when the journey is over, as difficult as it is to think about the end result of the journey, and when the journey is over, chances are that as a caregiver, you're going to be 10, 12, 14, 15 years older than you are when you got started. You are not going to be able to be the same kind of person that you were at the beginning of your journey. So the mindset is when this thing is over, I'll be able to go back to what I was. That person no longer exists. So anyway, those are two things that I think it will be important to have in mind. To have documents like a medical directive, emergency names, to have access to medications, the schedules for those medications, and so on and so forth. And then also, and this is another difficult conversation, is to deal with a season of hospice. Connie was in hospice for a year. That is a long time to have a hospice in being a part of it. But also it is very, very important to have a team that will be taking care of the hospice season, and also a team of people that you trust, that you feel comfortable with, and that you can learn from. It's just a learning experience all the way through.
Thank you, Senor Jose. Thank you for sharing your experience for the care that you provided to your wife. It was a long journey. We feel honored that you were here with us today to share that. And some of the things that you mentioned as a caregiver that the caregiver needs is with that support and care, with anticipating, learning, knowing what's going to come next, and that just-in-time support while you care and support the person you love, but also after that journey, that you continue to receive the support that you need in your own personal journey.
Make sure that you understand that during this time, try not to focus solely on your medical team. It is important, of course, no question about it. But there are other sources of assistance that can come from other places. And you will learn from those sources of assistance from different support groups. And many support groups, they rely on technology like we are doing right now with Zoom. And this is wonderful. And the support group that I belong to was a lifesaver for me, and it was wonderful, and I learned a lot from them. So that is, logistically speaking, you will get a lot of the information that you need from one day to the next from a support group, and don't be shy about shopping around to see which one fits better.
Thank you, señor José. Muchas gracias por estar aquí. Please
Yeah,
stay with
thank
that
you.
until the end. There might be questions for you as well into
Sure. Mhm.
the Q&A
I'll-
at the end.
I'll be
But
glad
at
to
this
take that.
point, I'm going to hand it off to Dr. Ana Chodos to talk about CAPCT and how some of these elements that you spoke about might actually appear in this training. Dr. Chodos, welcome to today's
Thank you so
webinar.
much. Can you see the slides okay? Okay.
Yeah.
Thank you so much. And of course, Jose, I think we would all benefit from hearing about your story and Connie's journey. And you know, for as long as we possibly could, just really appreciate what you were able to share. And I hope to tie it into some of what I'm going to present today. Also, just want to say thank you to everybody and the Bold Center for really highlighting this program. We consider ourselves a sister program of any effort to support caregivers. But here in particular, I'm going to highlight the work that we're doing in this program called Caregivers as Partners and Care Teams as part of the National Caregiver Support Collaborative at the Administration for Community Living, we're one of several goals. Really the reason this program exists is because of the work that folks like Jose are doing. He's one of literally millions. So we know that most home care for people needing support because of a chronic illness is provided by informal and unpaid caregivers, that approximately 53 million caregivers are providing care every day or some days of the week to increasingly complex individuals. So as we're aging in this country, we're getting more medically and socially complex, and that caregivers really have their own, they take their own toll for doing this work. And I think Jose was alluding to the fact that time passes, and as you're aging, things are changing. But also we know that caregiving directly can affect a caregiver's health. So we are part of this effort, this national effort to bring recognition and increasing attention to the need to address caregivers directly and their needs for support for their well-being. If we want to look at this in a way, the way a typical healthcare analysis or outcomes effort would be framed, we could say, well, this also really, really improves the care of and the health of the care recipient, not just the caregiver. So if we need to justify it in that terms, but I think hearing Jose's dedication and what he was sharing, it's pretty obvious that, the health of any person is really what we're here to do in healthcare when we're engaging in healthcare as a healthcare team. And so we are really point out that the healthcare team is incredibly essential for identifying, engaging, and then assisting caregivers in any healthcare setting. However, we know the need is huge because when research is done, when surveys are done, we see that healthcare providers and other team members on a healthcare team really lack any skills or consistent approaches to working with caregivers. So we really want to work with healthcare teams around building that as a core skill. Like, this is not an optional or a one-off skill. This is core to what we do in healthcare, is if there are caregivers, that we're identifying them, we're engaging them, and we're helping them. So that's sort of what this program's about. Just a little more about the background that I already mentioned casually, the national strategy to support family caregivers. Our program is one of 6 that was created by the Administration for Community Living to be the first national effort to support this national strategy and the key goals within that strategy. We are the primary goal really facing towards healthcare. A lot of the other goals are doing incredible work to support caregivers in general. But we really just have our sights fixed on healthcare and improving healthcare teams' abilities to engage caregivers. So here's our program, a brief overview: Caregivers as Partners and Care Teams. So we want to advance inclusion and engagement of family caregivers within care teams. And so really how we're doing that at the moment is through education. So we're creating training and education, both online modules and live, to provide healthcare teams with skills and confidence to include family caregivers or caregivers broadly defined in a patient's care journey. Really the core pillars here, which we sort of teach and keep coming back to are the skills around identifying who the caregivers are, who's that patient's caregiver team, engaging them around their role. That includes the aspects of like actual job skill and knowledge, and then also well-being. That's a big part of the role, like emotional and physical well-being. And then the last is having some skills as a healthcare team in connecting caregivers to the resources they need. And Jose was alluding to things like support groups, all the things that are outside of healthcare. We don't have to do all the support, but we have to know what those resources are once we've identified the needs that they have. Just want to say there again, there's actually really great evidence that engaging family caregivers in our healthcare team is crucial to a patient's journey, and it really benefits everyone. So one, it helps us provide better care. So we get real insights about how the patient is doing. Patients and caregivers have higher satisfaction if we engage them. And so they report their care as better. They report better quality of life if they're prepared for their role and if their emotional well-being is addressed. And then there's a reduced risk of things like repeated hospitalizations, unnecessary hospitalizations when we're engaging caregivers. So lots of good evidence, thankfully, and our gratitude to those who have done that work. I'm here representing an incredible team, my own team at UCSF, which is really helping to just keep this program on track and productive. But then we have these incredible partners who are very invested in this mission as well. Our colleagues at the UC Irvine Division of Geriatric Medicine and Gerontology, the Global Brain Health Institute, which is based here at UCSF. So we have a lot of folks from other nations who also work in caregiving and bring really valuable perspective to general principles of engaging caregivers. The Archstone Foundation, which is a California-based foundation focused on improving health of older adults in our state. And then we do a lot around the medical legal needs that come up with caregiving. So we work with incredible colleagues at UC College of the Law here in San Francisco. Also, I'm just so pleased to be on a webinar with colleagues from all over the country, just to really help strengthen the work that's done all over. And I just realized we're really California-based right now, but we're reaching out to partners across the state and always looking for collaborations. So just to give you an example of some of the trainings and resources we've created, we have our core course, which we call really creatively, Foundational Skills for Engaging Caregivers in Healthcare. We have some supplemental short, but like deeper dive courses on some of the core topics in that foundational course so that people can get a little more skill. And then we're looking towards and developing very actively courses for different populations. So for example, the grand family situation where an older adult or an adult is the primary caregiver for a minor that's not their direct child or the same or one generation below, but generally two or more generations below, for lots of different healthcare settings. So our foundational course is a little primary care heavy, just as like kind of a starting place. But now we're doing skilled nursing homes, hospitals, emergency rooms, and then doing topics like caregivers for adults with disabilities or lifelong developmental disabilities. And then, of course, really focusing on dementia, which I know is the topic of the day, because dementia is a really intensive condition for the caregiver in a lot of really particular ways, not exclusive to dementia, but really particular. So really focusing on that as well. We have resources on our website. We have a caregiver identification tool, which I'm going to show again later. Billing guides, because now Medicare and other insurances are more increasingly recognizing that we need to be reimbursed for the time we spend working with caregivers. It's also, of course, an incentive. It facilitates this work being done in the real world, in real life. And then different resource guides and website links and things like that. We're really trying not to reinvent the wheel, but do want to help bring some of the resources like in one place so people can find them. Just a little bit about process, and always open to more people joining us, frankly. But we do the creation of all of our content with the partner organizations that I presented. So people are in the field clinically, in law, in practice. We also engage subject matter experts, so physicians, nurse practitioners, physicians assistants, social workers from all over different disciplines. And again, particularly when we're entering into territory that's not as familiar, like the grand family territory, excuse me, we connect with organizations that this is what they do because we really want their perspective. We've also had a lot of caregiver input, and we do have a caregiver, a group of caregivers, a number of them on our advisory board and available to review our materials, thank goodness. So an example of our foundational course, we emphasize it's not meant to be just for a clinician, like the primary clinician, but has a lot of skills for everybody, social workers, care navigators, nurses. We offer free education credits, and we try to demonstrate how to do these skills. So we have case studies and some video examples of how you might engage a caregiver. And we are starting to offer live trainings more than just the modules. We tend to actually have better engagement and better attendance at live trainings, despite everyone being so busy. I think they are more often likely to make time for a live training than a module, in their spare time kind of thing. So we can really tailor these also to who's the audience. Is it more social workers? Is it more primary care physicians, hospital physicians? So these are, and we just have one example. We had a series that was done as a webinar and case focus series on these topics here. So caregivers, the core material of the course I'm showing you now, one on dementia, how to do dementia assessments in primary care, how to identify legal needs associated with caregiving and how to address those legal needs, and then things like how to integrate that into practice by considering clinical workflow, billing. I know, super exciting stuff, but very important. I just want to make one other point here about the actual education itself. That we really try to focus on everything from how to start a visit, how to engage a caregiver simply by acknowledging that they're there in the room and making it explicit how we're going to work together in this visit. So it has to be pretty basic, because I think one thing I didn't really touch on is there's a general sense that providers, healthcare teams across the board don't have these skills, but I think it really that cannot be bolded and underlined enough how just completely ad-libbed this is. So we just really do not see or have a standardized approach for engaging caregivers. So we really start from just like the very beginning of doing that kind of work. And then once we've done some of those foundational skills around identifying, engaging, and supporting, we have some more material on that, basically. So deeper into how to really identify, go through what the role is of that particular caregiver, what their needs are by knowing what their role is. So how you can connect those two things, how to really focus on some communication skills with caregivers to be very open-ended. So somebody like Jose may have very different needs than somebody else, and may have a different level of preparedness around being able to address those needs. So we want to really teach open-ended, but yet useful communication tools to find those unmet needs and start to tailor the kinds of interventions you're going to offer to the person. And then supporting, we're all over the country, so this is a really broad topic in the sense that we can't be too specific. California is just going to have a totally different set of resources than Oklahoma, but we really want to give you a sense of the general category of resources. At least we have, I believe, still, general resources and organization of resources like area agencies on aging and things like that. So how to find those and start to build your own resourcefulness as a healthcare team member in finding those resources. An example, so in the identifying section, we really talk to learners about how to, introduce yourself, understand where the caregiver is coming from. And we create a worksheet. It's not meant to be overly prescriptive that people have to use this worksheet, but it's really meant as an example of what we're talking about. What do we mean by identifying the caregiver's role? So we want to identify, I realize it's kind of small print here, but to the caregiver and the patient, how do they identify this caregiver's role? what are they doing? How are they supporting basic activities of daily living and instrumental activities of daily living? So all the things you have to do during the day to get through the day, you know, bill paying, transportation, dressing, are those the kind of things that are being, that this caregiver is assisting with? And how to do that, you know, in a relatively open-ended way, like how are these things getting done? Oh, okay, Jose's helping with those things. Wonderful. You know, tell me a little bit more about that. And then also, you know, sort of how ready does this person feel for those tasks? And so you can start to spot gaps or areas where really just get that visual, get that understanding of how someone's providing care. And so you can understand how to start to address the needs there. Again, just a quick visual example of our billing guide. We're trying to keep these updated. So if you are in a position to help your system incorporate these billing guides and make use of them, you know, you can attach billing codes to encounters where you are the patient's there and when the patient's not there. So we're just trying to kind of show the way there and help people find that information quickly. Again, I think I already foreshadowed this, that we're preparing other courses. So different healthcare settings and different caregiver types or groups that may have different specific needs. Again, today being about dementia, there's a real specific set often of one, resources, and two, needs that often are present. I just want to give you a second to just find us if you'd like to. We have a newsletter and a LinkedIn. We have a email that please, you're very welcome to email us if that's the easiest way, capct@ucsf.edu. And then our website is a good hub for everything if you need to find us. Today we're talking about dementia. And so we have a sister program called Dementia Care Aware. That's actually how we got started on this path. We started with Dementia Care Aware with a real passion for improving early detection of dementia. So there isn't a question when people are having really pronounced symptoms that, you know, we're hoping to catch things earlier. And, you know, these things evolve differently with everyone, but really making brain health, cognitive checkups a routine part of care. So that's where we started. But when we developed the program, we actually developed it so that when we advocate for what we call the cognitive health assessment, I'm realizing that's abbreviated here without additional context, so sorry about that. But the cognitive health assessment is our dementia screening approach. And we call it an approach because we train people to screen for cognition and for function, which are key things you need to know. So that's for the patient, and to assess if there's a caregiver. So in the very early moment of doing a dementia screen, you're already starting to embed an understanding and a concern and a need to assess and address the needs of a caregiver as well. And so we're just highlighting some of the resources. If dementia is a specific area that you're working in and would like more training or support, either just general education, you can check out our resources, or we're also very happy to connect over like coaching for a practice to embed caregiving screening and dementia screening, or one or the other. Very happy to support in any capacity that we can. And finally, I want to highlight this tool, Clarity. So this is a relatively new tool. It's already live, but there's something called Clarity Pro, which is really going to be for us in healthcare to learn more. That starts in July. And this website walks people through. So I think we've all heard of advanced care planning. And advanced care planning in the medical setting is often really focused on medical decisions. Clarity is sort of the companion for legal and financial planning for caregivers, with caregivers for caregivers. So, you know, if you have a caregiver, great. If not, this is still a very relevant tool. So we think, again, in healthcare, we just really importantly emphasize, you know, who would be there for you if you can't make decisions. Let's get that, you know, documented, figured out, supported, made as a legally appropriate plan, you know, so get whatever in your state is the appropriate paperwork and the appropriate sort of process, and make sure your healthcare team has that, all of that. Like, I go blue in the face talking about it all the time. What is a lot harder for me is to walk people through the legal and financial planning, because I can barely do it in my own life. So I'm not the greatest resource for patients, but I know how important it is. There's no world in which you would do the medical planning and not the legal and financial planning. They're absolutely the two sides of the same coin if we're just planning our lives and planning for the future, especially with chronic illness and doubly, especially with dementia. So Clarity is coming in to help people, guide them through the process. It has all the states and all state relevant information. And now they're coming out also with training for people like us who are professionals to help connect people to this tool where it's useful. So just want to put a plug in for that. And I think I've talked long enough that hopefully you have seen the email of Elizabeth Peters, in this case, Peters Elizabeth at uclawsf.edu if you are particularly interested in this and want more information. So just a thank you, and I will leave my email up as well. Hopefully you can get it if there is a specific connection you want to make about CAPCT. So thank you. I'll just transition there. Thank you.
Thank you, Dr. Chodos, for this overview. What a great program. We are thrilled really to feature it today. I mean, in addition to the information that it contains and all the demonstrations of those interactions between providers and the family caregiver and the patient, it really has a lot of practical tools and resources the providers can really take and implement right away to improve that communication and better help the caregiver support the patient outside of the clinical space and at home and support themselves. Thank you so much. So from here, now that we have had this overview of the CAPCT program, we will have a conversation. We will hear from next from our South Carolina BOLD program about their work in this space. So welcome, Carolyn, to today's webinar. And can you please start by describing the work that you and your partners have done in South Carolina to understand training needs providers have?
Yes.
Yeah.
Yeah.
Thank
you, Alma. So yes, again, I'm Carolyn Tremblay. I am a BOLD program manager here at the South Carolina Department of Public Health. So, and I just want to acknowledge, this work is not done alone. So, my coworker Jessica Player is our BOLD program coordinator, and Jillian Cato is our director of research and planning. But one aspect, of the implementing public health strategies to address Alzheimer's disease, we followed, kind of Anna's lead, but like, what do the primary care providers need in South Carolina to address Alzheimer's disease and related dementia? So if we could go to the next slide. So again, this is a BOLD grant strategy, is, to think about what the primary care providers need, what kind of training, and to incorporate caregivers into that training. So everything that, we just learned about the CAPCT program sort of fit what we found through the primary care provider survey. We initiated this survey in August of 2024. And we closed it in December of 2024, started the data analysis in January of 2025. So we've not published anything from the survey. This is kind of our first just general discussion around the questions that were included in the survey. So one of the key findings was that many South Carolina primary care providers are consistently reporting that there's uncertainty around the use of assessment tools and the process for diagnosing ADRD. Go to the next slide. Just so you can see, we had 73 respondents. Again, it was practitioner focused, so we wanted physicians, attending residents, nurse practitioners, and physician assistants. And you can kind of see the overview. The majority were attending physicians that responded. They were working in hospitals or healthcare systems, and also looking at kind of the, the location where their office was located. So was it an urban, suburban, or rural area? And it was pretty well split, so that was helpful for our analysis. Next slide. So just again, rank the reason for a late, ADRD diagnosis. And the majority had said the lack of, testing that's available, lack of time during the appointment. So again, pointing us to needing some assessment tools and looking for additional, resources. We did want to ask about the racial and cultural barriers that was brought up. 26% did acknowledge that sometimes the conversation is difficult. And all I can think is you need the caregiver to be there to help address any stigma or cultural barriers that may exist between the primary care provider and the patient. Next slide. I was, kind of concerned about this question, but were the PCPs worried, primary care providers worried about the consequences of making an inaccurate ADRD diagnosis? And it's between strongly agree and agree, they don't want to make an inaccurate diagnosis. So they're, again, pointing to the direction of increased training. Next slide. Limited knowledge of resources and services. So do they have sufficient knowledge of available ADRD services and resources? They do not. Do they have it or do they not have it? And many do not feel that they have sufficient resources. So again, we were just trying to make sure we're going in the right direction of offering support for training. Next slide. Is there enough training or not enough training? And most said that they do not have adequate training to diagnose Alzheimer's disease and related dementia. Next slide. So with these gaps, a portion of our survey really did focus on what training would they want. So the next slide. And rate each of the following training topics on a scale of 1 to 5, 1 being not interested, but 5 extremely interested. So caregiver support and resources was the providers said that they were extremely interested in that. Developing these community partnerships, and then the early detection piece and diagnosis of screening. So again, just when I was out there looking for what kind of programs are other states offering, the CAP-CT program really stood out as aligning with what we were finding in South Carolina. Next slide. Did they want it in person or virtual? And were they interested in making sure that the training had continuing medical education? So that did stand out, that they do want CME credits, and they want the options of virtual and in person. It's, those results were pretty close there. So next slide. And just an open-ended question regarding your experience. Diagnosing and treating Alzheimer's disease and related dementia in a primary care setting. There were a lot of patient and family misconceptions about the services they could provide. They really mentioned that they could use increased caregiver support, expanding the community resources. And just as as a health system, there's limited time for ADRD assessments. They want to be able to follow up on the diagnosis and the outcomes. And then there are insurance and cost barriers and excessive wait times to see a neurologist or a specialist. Next slide. So Elba kind of, had said, she brought it to our attention how what we were finding in our primary care survey would go along with what the CAP-CT program could possibly offer us. So what I noticed right up front, like how would this work in South Carolina? I thought, developing a dementia care pathway that includes the caregiver would be an excellent resource for our providers in South Carolina. And I really wanted to start the conversation around brain health. As a bold program manager, that's, we're following this Healthy Brain Initiative roadmap. There's a lot of toolkits around brain health and how to get the conversation started, but how are the providers trained to have that conversation? And then I just want to add the resources that I found looking at the website was the billing assessment tools, and then this connection to the dementia care aware. That's how the two programs I saw were aligning. Elma, is there anything else you want me to add to that?
No, this, we were really interested in hearing your perspective as a public health department who is helping develop this training in your state. How could you use CAP-CT? If could you?
Yeah, I think
Yeah.
the model itself it's so well organized that that's something I can present to my leadership, and we can think about that connection through our advisory council. We can discuss this platform with the providers that completed the survey. So I really think we can take the tools that were presented and apply them through our advisory council. And I know that's, kind of the goal of BOLD is to make sure we're getting feedback through our advisory coalitions or councils
Mhm.
and not just offering a training that isn't needed. So I see the alignment here.
Thank you so much. Thank you, Caroline. And I apologize to everybody. My internet is cutting out, so my video is off. But I would like to hand it off here to our team from Oklahoma, Dr. Strong and Klaczynski, to talk about their work there with the Caregiver Echo and what all it covers. So welcome. Keith, I will hand it over to you.
Thank you, and thank you for having us. We appreciate the invitation today to talk about some of the work we've done. I'm going to talk about our Caregiver Echo, and then Patricia will talk about CAP-CT within the clinical context here on our campus. We're part of the University of Oklahoma Health Sciences campus in Oklahoma City, so an offshoot of the main campus in Norman, but a academic medical center. Next slide, please. So, full disclosure, we actually learned about the idea for a Caregiver Echo from the University of Wyoming. And both of us are recipients of what's called a Geriatric Workforce Enhancement Program grant from HRSA. And they had been doing a Caregiver Echo for a few months when we found out about it and asked, said, hey, can we replicate something similar here in Oklahoma? They said, please go right ahead and please do so. So what we did is, if you're not familiar with Project Echo, I'll give you a real quick synopsis because I want to give Patricia time. It's really not a webinar, it's more of a learning interactive thing on Zoom or another online video conference platform where you get a presentation. Then sometimes you get like a case presentation. So I'm having this issue, and then your colleagues and you talk about it, and you usually get help from a specialist who may be able to help you with something professionally you're having a hard time with. This originally became a mechanism for primary care practice, linking to specialists within medical care, and it's been exploded to all kinds of different things. So it's a really cool model. Their motto is all teach, all learn. Right. And so what we do with the Caregiver Echo is we've been offering this monthly since April of 2024. And roughly to date, we've had about 80 caregivers come, and we get about 5 or 6 a session. So what we do is we open up a session and we offer a topic. And we get the topics by asking caregivers what they want to talk about. What do you need help with at this time? And this is really focused on dementia. The program name for our Geriatric Workforce Enhancement Program grant is the Oklahoma Dementia Care Network. So we are focused on dementia exclusively. Not totally, but really that's what we want caregivers to get information from us about. So they'll ask us for some things about, activities of daily living. That's what AADL is. IADLs are instrumental activities of daily living. So those are things, ADLs are like biological function, things that caregivers deal with, and IADLs are things like societal function, using phones, cooking, navigating, running errands, driving, things like that. Avoiding triggers that cause people to have behavioral episodes when they have dementia, being able to effectively communicate with the person they're caring for with dementia, their own stress. We also offer other programs for caregivers in self-care, because if caregivers don't take care of themselves, the care that they offer suffers. And unfortunately, sometimes they may pass away before the person they're caring for. So we want the caregivers to understand that stress is real, and it's something they should take seriously and try to navigate the best they can. Learning from their emotion. The nice thing about this Echo is it often becomes like a support group. So we have a few Echoes that we run here in our set. We're a part of the section of geriatrics and palliative medicine. We have one that we do for nursing home administrators and nursing home employees. We have one we do for like community health workers, social workers, other community-facing health professionals. And so Those I sit in on and just kind of see how they're going each time we offer them. The caregiver one I started to, and then realized this is kind of a support group. This is very private. This is an opportunity for caregivers to share their stress and their emotion with each other. So I don't go to these anymore. I actually, if we need anything for them, ask the person that runs this, what do you need? What can I help you with? And let them create a more intimate environment where things that are difficult can be shared. So learning from emotion, right? Sometimes those emotions can be negative and they can be difficult to deal with, but caregivers find out that other caregivers are experiencing this, and maybe it helps them feel a little bit of catharsis. They want to hear about assistive devices. Those of you who work in occupational therapy especially can tell people that there's thousands and thousands of amazing assistive devices for people, not only that are living with dementia, but people that may be living with some sort of functional limitation. And so, they want to hear about these things. And we always ask about the next future topic. What would you like to talk about next month? Or what would you like to talk about in the future months? And if we can, we bring an expert in to talk to them for maybe 10 or 15 minutes in a didactic sort of, hey, here's what I do way, here's what I can tell you as part of my expertise about the situation you want to hear about, and then offer them an opportunity to ask questions and really get some feedback. So this is proven to be a pretty good thing and a pretty cool opportunity for us to reach caregivers here in the state of Oklahoma. Next slide, please. And so again, you're not alone. You need a team. We want them to have knowledge to help take that knowledge to the providers that they're working with the one they're caring for, right? And these are caregivers that are unpaid. These are family caregivers of loved ones. And we want to help them access resources that can help with their care. And we want them to share that with health providers. You saw the last slide deck. Providers don't always know what resources are available, especially for people who are living with dementia and their caregivers. So we want to be a bridge there to help them out. I put a picture of one of the flyers we use to advertise this. We have channels on social media. We have a website. We have various ways we try to promote this and let people know this is available to them. In addition to things like the support groups that the Alzheimer's Association may offer. Next slide, please. I'd like to turn it over to Patricia now to talk about how CAP-CT is working within clinical spaces here on our campus.
All right. Thank you, Keith. Great presentation. My name is Patricia Chong. I'm a PA at OU Health Memory Care Clinic in Oklahoma. And so we'll be talking about CAP-CT. I actually went through the training to CAP-CT just to see, what it's like, how I can implement it in my practice. And I found that a lot of it is already components that I kind of do in practice just because my patient population are own dementia patients and providing longitudinal care to help provide more support for a patient living with dementia and their caregivers. And so I do think that it's important to have caregivers involved in patient care as they are the ones that have the more insight, understanding what their limitations are, their daily activities, and making sure that they're healthy and safe. I do want to disclose that sometimes it is difficult to sometimes implement CAP-CT just because there could be some resistance of patients not wanting to receive help from caregivers, not wanting to hear about their changes, and sometimes just some limitations sometimes in other clinical settings where either primary care or maybe specialists do not have time to fully engage caregivers due to time limits with their schedules. But these are some of the components that Dr. Shotos kind of talked about, understanding the context for the patient. It is very important. In our clinic, we do screen for a social determinant of health and review it just to see what resources that we can provide for patients. We can try to connect them with community organizations to meet their needs to kind of keep them healthy and safe. And also we can refer over to social workers for additional resources as well. And then providing a better care experiences as well. It is important for caregivers to be involved in the care team because, like I mentioned before, is that they are the more reliable informant sometimes, as there could be decreased insight of what's truly happening to our patient population. And so by getting good history, we're able to address what really matters most to patients and what really matters most to caregiver, kind of like Mr. Jose mentioned that I wish, the provider is able to kind of explain the prognosis a little bit better, what to expect as the disease progresses, and so just kind of identifying, what matters most to patients and their caregivers is important, and inviting who are providing these assistants too, so that way if there is some safety concerns, we can just kind of discuss about that as well. And then by providing more patient care experiences too, we can improve patient health care outcomes by improving the quality of life of patients and also the caregivers, as well as we're able to develop more of a personalized care plan to address what they need, and how we can help them as well. So kind of like Dr. Shodas mentioned, making sure that we're identifying who the caregivers are, engaging them in all discussions, care plan, maybe, even calling them afterwards, just so that way we can figure out what is the right plan for them and do our best to support caregivers. Helping caregivers feel better prepared is going to be important for us to kind of understand the challenges of what caregivers experience. So we do administer caregiver assessment burden scores just to see, where, how are they feeling? Are they feeling stressed? Or do they feel overburdened? They feel like they need more resources. So we do administer that in clinic, and then we address what other resources they may need and connect them with community organizations. So we do refer over to OHI, Oklahoma Healthy Aging Initiative with Keith Project Echo, dementia caregiver classes, refer over to Alzheimer's Association, respite agencies as well, and also an emphasis important of support groups as well. And then having a good caregiver also provides better understanding, helps caregivers understand dementia progression and understand how to address behavioral symptoms and skills and strategies for that too, how to cope with some of the stress that they may encounter, and just kind of validate their feelings that, this really is truly a difficult situation. Being as a primary caregiver, and emphasize, to make sure that take care of their mental and physical well-being as well. Because we understand that, caregivers are the foundations to ensure that patients living with dementia are safe and healthy and cared for. So when caregivers are feeling more prepared, they're most likely, hopefully, report less stress, less depression, and hopefully a better quality of life for themselves as well, and reducing risk of hospitalizations. Just engaging caregivers to continue to be proactive, reach out to us whenever there is concerns, rather than wait till something bad to happen, then get admitted to in that aspect too, and focusing on maintaining good health, addressing behavioral symptoms right when it starts, so that way we provide strategies to prevent inpatient psych admission or delirium, and then keep patient engaged and independent as long as possible to really maintain their quality of health. So I think implementing that in our clinic is important. So we have been very lucky that we are also participating in the GUIDE program as well. So we do provide a little bit more respite and more care coordination. We do have care navigators through the GUIDE program. And so that's kind of what I've been benefited from the CAP-CT, and seeing how much emphasis that the caregivers play a huge, crucial role into making sure patients are doing well, but also emphasize the importance to make sure they also take good care of themselves as well throughout the journey. And I'll give back to Ms. Alman.
Oh, thank you. Thank you, Dr. Trong. This is excellent, and it's really great to see here how you highlighted from the provider's point of view how caregivers help them, and what it really looks like during that clinical encounter, how best to integrate caregivers into that conversation, into that care. We have had a number of questions in the Q&A. Thank you to all of our speakers for answering them live. If anybody in the audience has more questions, please submit them, and we still have a few minutes to answer them. I do have a couple of questions that I'm going to ask, so I'm going to give you some time to phrase yours and submit them. And this first question is for the Oklahoma team, Dr. Strong and Kaczynski, about the echoes. Do you have ECHO or work groups for caregivers or providers that serve or convenes caregivers from small cultural or linguistic communities? Are there any of those currently that you're facilitating?
So, and I'm also trying to do the chat. So if you message us in the chat, I'm going to try to get to it. So
Sure.
give me a minute. So one of the things you navigate here in Oklahoma is about a 37 federally recognized tribal communities. So we don't necessarily focus on that per se, but that does come up. So we have another ECHO that I was just plugging for somebody here, and that deals with providers in the sense of, if you think of a social worker or a community health worker as part of the healthcare team as a provider in that way, that focuses on what they're looking at. And so somebody had asked me, what do you do? Let's say you're not in Oklahoma, but you have somebody who is concerned about dementia systems, but doesn't have a primary, care home. That's the ECHO where they talk about situations like this, like how other community health workers have linked people to community primary care homes and situations like that. That ECHO has quite a few of the other word for a community health worker in tribal context is community health representative. Has a lot of community health representatives attending it from multiple states. So while we kind of gather resources that are here, they can share things that they've encountered in their travels in the states that they're operating in. So that may be of use to people who are interested in navigating this situation with specific cultural and or linguistic groups. One group we'd like to reach more of is Spanish-speaking communities, which, if you're not aware, this, especially in Oklahoma City, there's a large Spanish-speaking community here. We have a colleague who's developed a dementia training for community health workers, and they do it in Spanish. And we've done it a couple of times. It's hard to find a staff person for us that could handle that consistently. So that is a goal of ours. But the one culturally specific situation we encounter quite often is the tribal one. And as you may or may not know, but be aware of, dementia has different meanings in different cultural contexts. So there are ways of understanding the disease and how people approach it and how they talk about it that are different. And so we try to be thinking about that as we move through our work, especially with Project ECHO. What the beauty of ECHO, though, is when you, like, for instance, the community health workers get together and somebody can present a case. Hey, I've got this client that I'm working with, this patient. How would you handle this? And instead of us coming from here, coming from the university side saying, we should do this, it's another CHR, another community health worker saying, oh, I had that happen. Here's what I did. And they find that very helpful. So that sort of peer-to-peer interaction is really important.
Yeah, absolutely. Yeah, I personally really love the ECHO platform. How it's a new way really of information sharing, of knowledge sharing and learning. It's really a great complement where we started with CAP-CT as a training for providers. ECHOs give that option to caregivers as well to build their capacity to effectively communicate. It's that space where they can acquire skills, tips, and resources to effectively communicate and improve and integrate themselves into the care team as well. For Miss Carolyn in South Carolina, Carolyn, could you just reflect on how do you think CAP-CT can be applied to training in rural environments, in rural areas?
Yeah, I mean, I think I would like to hear from Anna as well. It's kind of like, are the assessment tools adaptable to the different urban areas versus rural areas? We've been using community health workers to, get placed in a primary care provider setting in some of our rural areas, and they can assist with the assessment tools. But again, there's this building of community and knowing that a caregiver is also at that appointment. So I just was wondering if the CAP-CT tools allow for, some differences between an urban primary care setting versus a more rural office.
Thank you. Thanks for the question. It's such a good one. And actually a couple of questions in the Q&A in the chat have made me realize, like, the increasing there's clearly increasing availability of community health workers. This is really something that is part of the care model now. And in a way, our very general resources maybe should start to get more specific about the fact that, you know, this is flexible, adaptable to whomever is sort of playing a role. We shied away from overemphasizing this idea of a caregiver team, which is very real. Like, so, you know, a lot of times you will have, you know, the primary care recipient who has multiple people playing collectively the, you know, all the roles that need to get done. And that's what, one, ends up making it more sustainable, but two, is just practical. That's just life. And in this case, it seems to me that you would incorporate the community health worker as one of those team members on the caregiver team as opposed to the healthcare team. We just sort of, maybe it's a little old school, frankly, we kept it as like caregiver supporting, you know, primary care recipient and the healthcare team with all these, you know, tons and tons of disciplines and professions. So for us, I think this is really good encouragement to think about that, to think about how to call that out a little bit so people see themselves in the materials and see where they can use it to plug in to, you know, to help people out. But from a practical perspective, I really think of it as, you know, who is helping, you know, how are you getting these things done? Who's helping you? If anybody's helping you, let's just go through that. Oh, okay, the community health worker is really helping both of you at this point. So it's hard to create a perfect template for like all of the complexity of most people's lives, but anything we have is perfectly adaptable. We don't call it out in that way though. So maybe that's something for us to take forward and have learned from this webinar, and just want to express my gratitude.
Thank you. Thank you to all of our speakers. We are at time actually, but I know that we could continue. I would love to continue talking about this. I know this is a topic of great interest to our public health partners across the country, and I hope that health agencies who are here today in the audience really got some great ideas, learned about the work in 3 different states, and will reach out to any of these teams and to Dr. Chodas and her team to learn more and potentially even use CAP-CT in their own work with their partners. So thank you all for being here. Thank you to all of our speakers for answering all the questions in the chat, helping me keep track of that. Thank you, Keith. And then also for the Q&A. Y señor Jose, Mr. Jose, thank you so much for joining us today, for kicking us off and sharing your experience. Really, we are honored to have you.
It was a pleasure.
Thank you. We will resources recording from today's session will be shared within a week. So all attendees and registrants will receive links that our speakers have shared, as well as other information. So thank you again, and see you at our next webinar.